I have a couple.
All right, I'll start with you.
So we'll show you a chest radiograph on this person who is a hemodialysis patient, thus the big catheter going to the right atrium here, and maybe some other appliances related to hemodialysis or peritoneal dialysis down there. And then here's the lateral view, which caught my attention because with renal osteodystrophy, often the vertebral bodies become indistinct. You can't really see a nice sharp cortical line around the vertebral body, so they don't look like picture frames. Sometimes they're actually a little bit sclerotic, and the corticomedullary junction is hard to perceive, so that you get this sort of uniform whiteness through the vertebral body with not a clear sharp white margin at top and bottom and anteriorly. So it looks like a stack of marshmallows rather than a stack of picture frames. So in addition, this one, you get a hint. Could there be a central lucency going here in these lower vertebral bodies? It's hard to be sure, but maybe down here in the lumbar spine, so forth. But we do have a nice CT image here from abdominal CT that shows very nice central lucency in these vertebral bodies, and then the smudgy trabeculation, the lack of a sharp cortical line is brought out very nicely here with the CT. So this is the Rugger jersey pattern of chronic renal osteodystrophy with a central stripy lucency. It looks like a rugby jersey, so Rugger jersey sign of renal osteodystrophy. And this is a rather dramatic example. Now, I don't have a current chest CT to continue this on up, but I think the findings are actually more pronounced here in the abdomen. So I do have an abdominal CT from 2 years before, from 2018, and it shows not quite so much resorption here centrally, so we don't have as much of the stripy black stripe through the center of the vertebral bodies. So the only chest CT I have is 2018, so it would not show the findings as dramatically, but I think they're worse in this person probably in lumbar spine. So this is one of the most dramatic examples of the Rugger jersey sign of chronic renal osteodystrophy.
Very nice. Yeah.
Howard shares my relish of the renal failure manifestations. We should go back and look at the distal clavicles, because that's another site where you'll see resorption of that sharp cortical envelope. So it's probably here. We don't really have a sharp white line at the distal clavicle here. So that gets resorbed. Sometimes the AC distances increase. Sometimes you get a kind of striated pattern, looks like a paintbrush here at the distal clavicle. So in retrospect, I think he probably does have the clavicle disease, but not particularly well displayed here.
So question for you and Howard. Have you noticed a sort of a decline in renal osteodystrophy with just with improved electrolyte management over the years?
I think so. I don't have stats, but that's been my impression.
Yeah, because I see it only so often.
The other thing that I think we don't see so much of in the thoracic spine is the H-shaped vertebrae of sickle cell anemia. I think that's being managed better too. And it's rare, it's relatively less common now, I think, to get those H-shaped deformities of the end plates of the vertebral bodies. And I've thought that I've attributed that to better management. I hope that's the case.
Interesting.
Okay, then I'd like to show you this person who has chest radiograph showing a big heart and a very big hiatal hernia lurking behind the heart here. And on lateral view, let's see if there's anything of interest, not particularly, just low volume, some coronary calcification and so forth. And let's look at CT on this person, which shows this bizarre pad of tissue here alongside the spine. And this is a lot more pronounced than it was on CT scans from a few years ago. So we've got this bigger pad of tissue. I think this is just osteophytosis here. I don't think that this is erosion of the vertebral body. And then we get down to the right atrium here, and there seems to be a pad of abnormal tissue again here, surrounding the lumen here, which is encroached upon. So we've got this irregular pad of tissue. It's hard for me to tell whether this is myocardial or pericardial. Seems to be going into the notch here, where there's fat here at the that AC groove anteriorly.
Yeah,
So
David, I think the fact that it surrounds the right coronary artery because you have a calcific arteriogram suggests at least a component of it is not in the myocardium itself.
Yeah, so it could be in the fat, then in the subepicardial fat here in this location. Do you agree?
Agree.
Yeah. So here's nice thin pericardium up here. This seems to be in the fat, the subepicardial fat. Okay, and then we get down into Mr. Abdomen, and again we have some bizarre tissue that does not belong, and then very funny looking kidneys down here on both sides. They seem to be quite large and meaty. I don't have abdominal imaging, at least not handy. I was going to search to see if I could find some. So we've got this stuff in or around the kidneys, and this person at an outside hospital has had biopsy demonstration of Erdheim-Chester disease. So, you know, the perirenal manifestations, which are not as clear-cut in this case as I would like, I'll see if I can get better imaging of that, is just fine for that. And then these very funny locations of tissue infiltration here in fat, paraspinal fat here, and then probably in subepicardial fat, as Jeff was helping elucidate here, surrounding the right atrium and encroaching on it. So this was picked up on an echocardiogram. They said there's some abnormal tissue here. They thought was outside the right atrium, but surrounding it, and you know, it's encroaching, definitely encroaching on the right atrial dimensions. So Erdheim-Chester, I don't think this was a slam dunk case for Erdheim-Chester based on these thoracic findings. I think the perirenal disease is probably the best pointer to Erdheim-Chester.
Anything in the lungs or bones?
Lungs, no. And pleura, no.
And David, this was confirmed?
It on an outside biopsy, so I only have history
Okay.
in our record that said
actually,
it was diagnosed outside.
I was actually thinking you might be going lymphoma route instead of Erdheim-Chester, particularly with the kidneys, because it looks like it's more just a faceless kidney rather than all perirenal infiltration. And we've certainly seen cases of myocardial and epicardial involvement like this with both, but interesting.
Yeah, I agree, and I thought I would think of lymphoma first off here too. So, you know, just bizarre tissue, but it seems to be mostly fat otropic here. So we've got this in the retroperitoneal fat and stuff like that. And I agree with you. I mean, I can't really see where kidney ends here and where this mass begins. So it's not clearly perirenal. And the most common cause of enlarged kidneys is lymphoma. So, okay.
Excellent case.
Wow. Very interesting.
All right. Howard or Travis?
I can go anytime.
All right. The presenter.
Go ahead. I'm going to prep a couple more.
Okay.
Okay, let me show you the first case. This is a radiograph in a patient with a history of left lung transplantation for emphysema, COPD, transplant lung, of course, on the left, and the native lung on the right. I'm going to bring alongside the previous one and make some of those things go away if I can. And the findings are subtle, but I hope that you can appreciate, if you look at the left lung, you can discern there are opacities in the lung. How might one describe them? It's a little difficult, but I think people might use the words like reticular, or maybe ground glass, even though we don't usually use that for chest radiography. But clearly there's something wrong and different from before. And then we also have, as you'll see in a moment, some pleural fluid, which is new. And then clearly you're going to intuit that the process is affected by the fact that the patient has a transplant left lung, but an emphysematous and abnormal right lung. So let me show you, sorry about that, the CT that was done subsequently. Now this is from the outside. And now we can appreciate that what we have in the left lung are great signs of interstitial lung edema in the form of septal lines, peribronchial fluid cuffs, subpleural edema related to the major fissure, and pleural fluid. And the right lung, perhaps not surprisingly, is basically spared. I thought I might have seen a peribronchial fluid cuff or two, but a very dramatic difference in the appearance of this lung. And this lung is also quite opaque as well. Now, of course, we have contrast medium in the capillaries, so perhaps that just diffuse hyperattenuation is a reflection of that. But we have very clear-cut left lung interstitial edema and pleural fluid. And he was found to have a low ejection fraction on cardiac ultrasound. So we have asymmetric lung edema, the distribution of it affected by the presence of severe emphysema on the right-hand side. And then also by description, this is from the outside, they said there was a question of pulmonary embolism on the right lung, in the right lung on the outside. So let me show that to you now. And as we scroll through that, you'll begin to appreciate that we have apparent filling defects and abnormalities in the right pulmonary arteries. And another thing to notice while we're about it is that unlike the left side, there's no contrast opacified blood in the pulmonary veins on the right side. So clearly we have pseudoemboli, and we have the effects of relatively slow flow and a mixing phenomenon in the pulmonary arteries. And indeed, in an area like this, I believe I see fluid levels, contrast, and non-opacified blood anteriorly. And you can see how, of course, unopacified the pulmonary veins are. So we have high resistance to flow, slow flow through the right-sided pulmonary vessels, and smoke, mixing, and flow-related phenomena in the pulmonary arteries as a consequence of that. So I was able to help them by identifying that flow phenomenon, and that's not pulmonary embolism. So a really interesting case of the presence of disease affecting the distribution of the lung edema and producing pseudoemboli. Do you guys agree that you would buy this for fluid levels? At least
Absolutely.
like here, for example.
Yeah, it's a great example.
Yeah, and then basically no contrast medium further down. Yeah. So a really nice example of pathophysiology in this particular context. Along those lines, here is, I believe, a really nice example of the influence of emphysema on the distribution of disease. So here we have a patient that has, again, very abnormal lungs. We have an appearance that would reasonably be described as reticulation, but it's not uniform. Here we have very coarse reticular opacities, perhaps less so here. Here we have the usual question of how much is pleural fluid, how much is lung atelectasis. Let me show you another frontal projection of the chest, which here looks better, but we still have this appearance, I hope you can appreciate, of what might reasonably be called a very coarse, strange reticular pattern, very coarse. And as you'll see in a moment, and I hope you'll be persuaded that this represents the adage where in lung edema, you don't get wet lungs where you don't have capillaries. So here's a patient with emphysema, and we can see findings of interstitial edema in the form of peribronchial fluid cuts most likely. But I believe this reticular appearance is a manifestation of interstitial edema, and the lung tissue between the cystic spaces of emphysema is wet. But where you have lung tissue, you get the reticulation, but otherwise it's a very heterogeneous distribution of lung edema influenced by substantial emphysema. And then we have pleural effusions consistent with transudates. Would you guys buy that?
Yes, and we see this on chest radiographs quite frequently. I think it's when you have bad emphysema, it can look more like a fibrotic lung than a edematous lung.
Yeah, and it's a very strange appearance. But it's a dramatic example, I think, of the influence of the emphysema on the appearance of the edematous lung. And it's a really hard thing to discern if you have comparison radiographs, and if you're lucky, if you have a CT, that helps discern what the abnormality is. Now, I don't know if this is hydrostatic lung edema from primary cardiac disease or maybe hypervolemic lung edema, but certainly consistent with that, I believe. Here's another one that I think that particularly trainees tend to not appreciate and can easily go by. So let me show you this radiograph. And just on the frontal projection, I'm going to put alongside a comparison from before. So December and January. Now, in between, the patient has had surgery. I think it was a cabbage. You can see sternal wire. So post-op radiography. But what I want to show here particularly are findings of left sub-pulmonic pleural fluid, and more than just a little. So here are the observations here. If you look at the basal chest, there is opacity. If you look at the appearance of the hemidiaphragm, you can appreciate the change. You can appreciate that we don't have normal left lateral costophrenic sulcus, and we also have opacity in that medial chest. But here's something that folks don't appreciate. If you're lucky enough to have gas in bowel in the stomach, if you see that there is a greater distance between the apparent diaphragm or that hemidiaphragm and the stomach, that tells you there's quite a lot of abnormality down here. It's an additional thing to look for. So you have left subpulmonic pleural fluid. Now let me bring in the lateral projection. And the previous lateral projection. And yes, we see some pleural fluid down here, but there's actually quite a bit more in the subpulmonic location in that basal left hemithorax than you would. So again, there's quite a thick layer of fluid here. So quite a few findings of more than just a few cc's of left subpulmonic pleural fluid. Do you guys ever pay attention to that or teach that or have used that as a potential additional finding, this apparent distance that is increased in the case of a left subpulmonic pleural effusion? And do you buy it?
I don't think we see it that often. I do use it to at least try to figure out where the diaphragm is, because
yeah, in other words, what I'm saying in part is there's quite a bit of subpulmonic pleural fluid lifting the lung up. Now the diaphragm may be anterior, but the opacity here is fairly substantive. I've seen that quite a few times and I sort of identify that, but I tend have to forget to teach the residents that's an additional finding of sub-pulmonic pleural effusion on the left side,
That's a good reminder.
where the stomach and the diaphragm are quite separated. One additional finding of sub-pulmonic pleural fluid right there, and it's quite a bit. I don't think there's a name for that sign, but I do see that not uncommonly. Let me show you this one real quickly. It's kind of interesting. So here is, I believe, a really nice example of, and I can just go straight to the finding, which is right here. So I'm going to make that big. And I'm pretty confident this is a so-called calcified fibrin sheath in that location. The patient must have had a catheter there maybe in the past for a long period of time, but it's basically two parallel lines of calcium in that location. At a first glance, it might almost look like a catheter, but of course it isn't. But finding is very consistent with the so-called calcified, which can happen. You can find quite a few case reports of this calcified fibrin sheath. And I'm not sure if I've seen such a nice example before, or maybe I haven't recognized it. But have you guys seen one quite like that?
What's one of the nicer ones I've seen?
Yeah.
Yeah.
Sometimes they almost can fool you as a retained catheter fragment.
Right. Yeah, I thought I had a PDF file that I attached to this particular case, but I had a nice example where they showed several examples of this and collected a few and wrote up a case report of that.
One that raises one question I want to ask all of you is how vigilant are you for catheter-associated thrombus? Because we all see a lot of malignancy follow-up, and I'll admit that I wasn't always looking at every catheter, but I tended to move more towards that because they treat them pretty aggressively here with anticoagulation if you see anything.
Catheter-related thrombosis, acute
Or catheter-associated thrombus, like not even complete thrombosis of the lumen, but just when you see a small little thing, you know, along the course of the catheter or the tip, maybe a centimeter, so low attenuation filling defect.
I don't feel like we see it that often. I mean, when we do see it, we sure let them know, but I
Do you
think
consciously look on every study? Because I certainly didn't used to, and now I've tried to because we missed a lot.
Yeah, I think one of the challenges is the contrast is usually really, really dense in the superior vena cava, because if we're doing a chest, abdomen, and pelvis, we do the chest pretty early in the injection. So it'd be pretty, yeah, I don't know. I mean, we look for PE, I know, so.
Yeah, no, it's just trying to assess other people's practice patterns.
I'm trying to think consciously. I mean, I'm always looking at the SVC, but
yeah,
I just haven't seen that many. I'll have to go look harder, I guess.
Howard, I've shown a couple of cases that Greg Kitchka pointed out to me of embolized fibrin sheaths. So they pull out the catheter and there's a little, cylindrical calcification sometimes left behind. And then with time, I've seen these migrate into pulmonary arteries. Have you seen any embolized? I think a couple of years ago.
No, I don't think I've ever recognized one that actually moved from that position elsewhere, from a position like that elsewhere, embolized actually.
Maybe I'll show one next week.
Yeah, we've definitely seen a few where you just see a small little really dense thing filling a pulmonary artery, and then look and see that they've had prior catheters and presume that's what it is.
Sometimes you can even see that it's a cylindrical calcification. It's not just a rod of calcium or a circle. It's a sphere. It's actually a cylinder.
Like this one? Yeah, with some length to it.
That's right.
Yeah. Yeah, this one that they showed in the article, maybe not as nicely as this one, but sort of has that thing too. They recognize that in ultrasound, and yeah, you can see they're trying to show that cylindrical nature to it. Yeah. Can't see it there. Yeah. All right, Jeff, those are mine for now.
All right, thank you, Howard. Travis, are you ready?
Yeah.
All right.
Okay, you should see a CT here. And this is an outside CT, and much like Howard's case, I think you can instantly recognize that there's smoke in the left pulmonary artery. Now, this was done just as a gated CT only through the heart, and this was part of like planning for AFib ablation. But anytime you see the presence of unilateral smoke, always think about some sort of either pulmonary artery obstruction or perhaps pulmonary vein obstruction. And so, as you can clearly see here, there are no left-sided pulmonary veins connecting to the left atrium. So this patient has had an ablation before and has been, and it must have been years ago, and I don't know when, but you can see that he has typical findings of just chronic venous congestion and like unilateral veno-occlusion with septal thickening. Some of this just scars that we often see, and a little bit of volume loss in this chronic effusion with some round atelectasis. Now, this was actually called positive for pulmonary embolism on the outside, but just to remind everyone, this is not PE. It's too ill-defined, and we have a good explanation. We're early arterial phase. There's just really no contrast getting, where contrast just doesn't have time to get through that left lung. And maybe in some areas you can even tease out a little bit of contrast layering, not nearly as nicely as Howard's, but that was done. And then I'm going to show you this, because this is like maybe the best and most interesting example I've seen in this sense. This patient had a repeat study 2 months later, and I don't know exactly why. This was also done at the outside hospital, but this time they actually gated it, and it was now called worsening pulmonary embolism with propagation into the main pulmonary artery, and as you can see here. But this is, again, just a textbook example of smoke in this case. And what's really interesting about this is that we have 4D images. And so I want to show you just how we can kind of see, as you move through the cardiac cycle, that smoke, the non-opacified blood pushing out and then coming back, and just all of this, the swirling and this vortical flow that you see there. So I just thought this was such an interesting example.
Yeah, that's great.
Gee whiz.
Yeah. David, you like that? I know you always like to talk about differences in flow.
Yeah, I love it. So you're probably, the contrast probably stagnates in diastole, and so you're actually, you're probably seeing a beat pushing the contrast out, and then.
Yep, and then it kind of refluxes back. It just has nowhere to go. So just a reminder that we still see a lot of these examples, and whenever, and you can make it look as dark as you want based on the windowing, but it's not. You need to, if you're really worried on this side, you'd have to do a delayed phase. And you can see here, if you look at it on just routine soft tissue windows, there is a little bit more time that's elapsed, because you can see there is some contrast getting out into these. And they're going to, our interventional cardiologist is going to try and see if he can find his way back to the left atrium from this pulmonary vein. I don't know, maybe there's a little nubbin left there, but I'm not hopeful in that regard.
So, Travis, you think? I think you pinpointed it faster than I did. So, don't you agree that contrast, that unopacified blood is refluxing back and forth?
Yep.
Into that blocked pulmonary artery?
Right.
So it distends up with a high pressure, and then as in diastole, it refluxes back out of that distended pulmonary artery. It shoots back.
Exactly. Yeah. And you can see there is some contrast mixing. That most of that was just a product of the window and level that I was using.
Yeah.
So there is contrast getting in there. It's just stagnant flow and a fast scanner, and you've got good temporal resolution to capture this kind of detail.
Kind of yo-yo
Mhm.
classified blood here.
That's
All
very
right.
true.
Then I've got 3 cases. I don't have a radiograph on this case, but we can look at the scout. This is a rather dramatic case that I saw a follow-up on recently that had a good outcome. This is a woman in her 80s who has type 2 diabetes and some level of dementia, and had been complaining of fever of unknown origin for 3 or 4 months. I don't know what prompted the CT, but she eventually got the CT, and you will see here that as we follow down, there's a left-sided pleural effusion, and you can see her aorta just kind of runs into that. And then, yeah, so fever of unknown origin, and this kind of look where you can see there's disruption of the wall of the aorta, and this calcium is going out. Certainly, you would suspect an aortitis with some sort of, I don't know if you want to call it contained rupture at this point. I think some of this is atelectasis. I don't think she had any history of hemoptysis, but her blood cultures eventually grew salmonella, and it was a non-typhoidal species, Salmonella enteritidis here, and that's how they speciated it here. And so salmonella is a common cause of aortitis in the literature, and there are increasing number of case reports now of these being treated with endovascular stents. And so there was still enough aorta for them to pass through, and this was done at an outside hospital. This was just the first post-operative follow-up study, and you can already see that there's still a little bit of fluid surrounding that and a little bit of gas, but we've had follow-ups since then. She's had a small type 2 endo leak from some of these intercostal arteries, but has done quite well. And she's on lifelong antibiotic therapy to suppress the salmonella infection, but much better outcomes with interventional repair of these and lifelong antibiotics than there ever was with open repair.
Yeah, tremendous advance. You have these stents available, this kind of thing. Tremendous advance. Wow.
Would you call this a mycotic aneurysm or pseudoaneurysm, or is that term not appropriate anymore?
I think I think by definition, a mycotic aneurysm is a pseudoaneurysm because you've lost the integrity of the wall. So,
Right.
Or a mycotic pseudoaneurysm, whatever you want to call it. Yeah, it certainly. I always think of pseudoaneurysms as just contained ruptures, and it's hard to tell. Certainly, this is something that needs to be treated, whether you call it a contained rupture or pseudoaneurysm, or whether you distinguish those two or not. But.
And how far down does it go, Travis?
It's pretty short segment here. Let me pull up the sagittal and you'll see. It's the breach is right here, so it's not. Yeah, and then kind of contrast up into here, and I don't know. A lot of this looks like it's lung. You can see some vessels in it.
Travis, did she have infection anywhere else in the body, or is this the only site?
They never found anything anywhere else.
Wow.
Wow.
Yeah.
Pretty lucky to survive that.
And then two radiograph eye test cases that I think are worthwhile to show. Remember, it was, I think last week, Howard, right? You showed a case of hilar enlargement that turned out to be pulmonary arteries. Now, in this case, I find it very useful to, and when I was training and even since then trying to improve my detection of things on radiographs, it's nice when you have a normal for comparison. This is a patient who has a cough, and this was 3 or 4 years ago. And looking at all the places where you can actually see new findings. First of all, in his lungs, you can see there's very subtle micronodules, more in the upper lobes. That's the one finding. But I think the first thing that jumped out to me was the lumpy, bumpy appearance of his left hilum. And then if you compare to the prior as well, I think you'll see that you would agree that it looks like there's probably something in his AP window kind of effacing that little notch that we should see there. The right paratracheal stripe, often difficult to see things, but looks a little bit wider. So once I see one site of what I think is lymphadenopathy, I'm going to look for more conclusive findings.
I think there's also subcarinal here too.
Yep, good. And I think you're right that you can see kind of the azygoesophageal interface before, and now just this whole area looks a little filled in, but that's what I was saving the lateral for. And I think that this is the subcarinal or inferior hilar window is always a hard one to discern, but here you can see what normal should look like with pulmonary veins, and the probably not the best position lateral. That looks like the intermediate stem line there. And now you can see what a subcarinal lymph node should look like, just way too much opacity in that area. So findings of the combination of nodules, I didn't really see much on the right hilum. He does have it on the CT, as you'll see. It hasn't been diagnosed yet because he hasn't seen pulmonology, but most likely this is going to be sarcoidosis. And you can see how large that subcarinal node is. He has some small nodes. The one thing that made me a little nervous is some of these nodes are heterogeneous, but his symptoms are pretty low level, just chronic cough, and of course the nodules and a perilymphatic distribution in the upper lobe. So he'll get workup for mycobacterial infections as well, and fungal infections, but he does not have a known cancer. So this is probably just going to be sarcoid with a nice normal radiograph for comparison.
Very nice.
Do you see anything in the right hilum on this radiograph?
No,
Not me.
no.
All right. Yeah,
So,
I agree. And then one more. Yeah.
Guys, I came across a case of sarcoid with a lot of upper abdominal lymphadenopathy. I wonder how often, have you guys seen that? I don't think I've seen more than a couple of cases over the decades.
Very uncommonly, and it was pretty modest at most.
I'll show it next week along with a silicosis case for comparison.
Good.
All right.
And then one last one I'll show, and this is finally got some follow-up on this case. This is one of the bone radiologists at the VA showed me this spine a while ago and asked what I thought, because this patient came in with back pain and thought the question was, do you think this is too much for just mediastinal fat? And my response was absolutely. There's way too much here, and I think on the lateral view it's probably all just right paratracheal in this case. And so I told them I was worried that there was some sort of bulky lymphadenopathy here. Also noticed like the left paravertebral interface looked a little widened, and on the lateral view, I don't know if you guys see anything specific here. It just looked full to me, for lack of it. The right hilar vascular opacity just looks a little too full, and I wasn't exactly sure what was here, but not seeing a normal or typical look to the pulmonary artery.
Yeah, we don't have a normal opacity of left pulmonary artery there. It's more than just that. And the more one looks there, the more one appreciates there's too much opacity in that region.
And it's lumpy, and there's no stem line.
Yep. It's like the more you look, the more you wonder about quite a bit.
Right. I think some of this is probably lymphadenopathy involving the intermediate stem line. But yeah, it was one of those ones that I couldn't articulate everything I saw that, or the location of everything I saw that was abnormal, but it certainly failed the eye test. This patient did have a prior radiograph for comparison from 3 years ago or something. Let's see if I can, crap. I hate this more informations thing. Maybe I won't be able to get that to show without changing the window. But anyway, I actually went to one of the other VA hospitals, and this is 2 months later. So things have progressed, but you can see all of this bulky right paratracheal lymphadenopathy. Clearly, we don't see this prevascular stuff at that time. He's got big axillary nodes, and then this right hilar mass that's just substantially progressed. Now, some of that may already be here, but it's considerably worsened. And this did end up being small cell carcinoma. And I think he had mets to his lower spine, but not to his thoracic spine. But it was just a cancer with workup prompted by the spine radiograph.
Wow.
Very nice.
Yeah.
Okay, let's see here. So this is a old case I lost and refound thanks to one of my residents. This patient came into the emergency department a while back with a history of chest pain and had a history of breast cancer and a reconstruction. And you can see the surgical clips out here, but there was this funny wire just kind of hanging out in the right hemithorax. So we got some button artifacts and stuff, but unclear exactly where this was. We didn't have a lateral, but the patient did end up getting a CT scan, and you can see there's this wire here, and I'll put a coronal MIP up in this flap. You'll notice there is a flap here, and this is a deep inferior epigastric perforator flap, the DIEP flap or deep flap. And so I was trying to figure out what this wire was, whether it was why it would be in there, because I didn't know exactly how far the patient was out, but it wasn't, I mean, it was an outpatient, so presumably it had been some time, and it doesn't look that fresh as far as stranding and stuff. But if we look at the MIPS here, let me see if I can thicken it up a little bit. Yeah, there we go. You can see this wire just hanging out there. So I had to do a little investigating and get some help from the breast imagers and then one of our abdominal imagers who does the pre-planning CTs for these. But this turns out to be a retained Doppler wire. They use these early after the procedure to make sure that there's good flow in these at the anastomoses, and they're supposed to take them out. And I don't know where this was done. This patient hasn't been seen here since. So I don't know if she was in town visiting a family or a friend or something, because there's no further records, and I don't think it was done here. But this is what this is. It's a retained little Doppler wire. So I'd never seen one of these before because we never imaged them with them in. They usually come out pretty early after the surgery. They leave drains in usually for a little bit longer. So unusual wire.
That's really interesting.
What does this wire do? How do you get Doppler information from a piece of copper?
It's unless I misunderstand it, there is a little microcatheter that goes into a vessel, or vessels plural, that monitors blood flow in the vessel supplying the tissue flap. Jeff, right?
Something like that, yes.
Yeah.
So this is
So
a
I've
guide
seen
wire.
that in this context, but I've seen that in the context, this one ENT surgeon here, that when he does head and neck surgery, and he does a tissue flap, he will put these microcatheters in the flap vessels, artery and vein, and they actually get pressure readouts for blood flow. And they're this slender, about this size. So I think, I don't know about the Doppler, I don't know exactly how they measure flow, but does that sound about right, Jeff?
It
Something like
does.
that?
Yeah, I don't know the engineering behind it, but I know that they use them to monitor. It's used in plastic surgery for flap monitoring, because this is a free flap, so it's everything is reanastomosed. But usually they come out after a.
Right.
This is a guide wire for the catheter. Is that right?
No, I think it's actually the actual part of the device.
Yep.
Okay.
But, yeah, well, like I said, I've never seen one before. None of us had ever seen one before because they're not supposed to be in there, and we don't usually image the chest immediately after one of these. And I don't know if it was related to her chest pain. I don't have any follow-up because she's no longer in our system, but presumably a surgeon went in and removed this at some point. And if we go back to
the ones I've seen for the neck surgery are about that caliber. They're very slender.
Yeah, see, they anastomose it to the internal mammary artery, so you can see there's a bunch of the wire right around in that area, but I don't, and it just goes under the skin, so I don't know where the communication is, why it was left behind, but they should be able to pull it out, but I presume that's what happened. I've never seen one since, never seen one before, so, but it was just one of these weird foreign bodies that required a lot of people smarter than me to figure it out. Okay, this is kind of a neat case. So this patient had a history of melanoma. I want to show the right one. And on a follow-up CT has this little cutaneous nodule, but had this other one down here. And this was a new nodule in the right breast here. And so it was eventually biopsied. And on the follow-up, and it was proven to be metastatic melanoma, and the patient had gotten some therapy, but was interesting on the follow-up CT, you can see it's gotten bigger, and there's this little calcium in it that was there before, but there's now little nodules along this little curvilinear track.
Oh gosh.
Yeah. So, and this is, this was done under ultrasound, and I don't have the images, but this is right where the biopsy was done. So, I don't have tissue confirmation, but I think everyone would agree this looks like seeding of a biopsy tract with tumor.
Hmm.
So yeah, I've not seen that with melanoma. You know, it's a rare occurrence with needle biopsies. It's like less than 1% reported, and we typically think of like mesotheliomas, and we don't usually biopsy thymomas, but that's another tumor that can seed. But this is clearly an aggressive melanoma since it's refractory to treatment, or at least this current regimen. And I suspect that's what these little nodules are, because as from the notes, there was no complication. This is not a very vascular area here. You can see there's not a lot of other tissue other than fat. So I don't think it's an old hematoma, and it's really along the needle track. You can see it going right into it there. So I think
That's a very good observation. Wow.
yeah, and I guess so if the patient gets another follow-up, I suspect this will follow whatever the primary sort this metastasis here does. This is something that came across on a let's see, on a PE study. So this is the older study here. So this patient had a history of staphylococcal sepsis, and had an aortic valve prosthesis put in. It ended up with endocarditis and all that stuff. I believe was an IV drug user. Also has a tricuspid prosthesis there. And on this follow-up study, there's been a big change at the aortic root. We see this collection here. So there's the valve, and the valve is just sort of this complicated collection. Let me make a coronal here, show it as well. So there's the aortic root right there, sinuses of Valsalva, and we have this collection sort of septated wrapping around underneath it there. So I think this is a giant root abscess here, and it's probably, and it's presumably just got reinfected. And if we go back, I don't think there's a VSD at this point, but it'd be very concerning that this is going to rupture into that right ventricle. But you know, and then you can see in the lung as well, we have what looks like septic infarct type picture here. This non-enhancing consolidated lung here. I can't remember if we saw in PE. I don't think we did, but you can get these septic infarcts or area of infection there. So, but this is one of the bigger ones I've ever seen that was rather acute. I mean, we've seen some chronic ones, but this one is quite large and quite complex. So, not good, of course, because this whole valve here is going to be compromised.
This is also a nightmare for the surgeons. I think the surgeons must dread having to try to operate on these patients because they know how difficult it's going to be.
Right. It's a repeat sternotomy. It's an infected valve. It's very probably friable tissue, and it's infected. This was just a little incidental finding I came across on I can't remember, it was like a lung nodule follow-up. There's this little fat here in the esophagus, so it's probably an intramural lipoma. Of no clinical consequence, but I haven't seen one in a long time. But just
well, that's a good pickup.
Yeah, just a curiosity, but kind of cute there.
One's been appreciating that.
No, I mean,
wow.
Yeah, I mean, it's just one of those things. It catches your eye because in this case, the esophagus is mostly collapsed, so it looks pretty homogeneous, and then you just get the fat right there. But yeah, benign, doesn't require any further evaluation at all. You know, I remember as a resident seeing big ones in teaching files for fluoro cases. It's just in the differential for a intramural lesion, leiomyomas, and then lipomas. Let's see, speaking of the esophagus, so this was a crazy case, and this is the radiograph here. So this patient, you can see has, I'll move so we can see it better. You can see there's gas in the neck. And so one of the things I always like to teach the residents is when you see gas in the neck or the supraclavicular fossa on a CT, it's likely coming from it's coming from the mediastinum. You can get it from a pharyngeal injury, but we tend to see them with pneumomediastinum, especially if they're having chest pain or any chest symptoms. And we don't really convincingly see anything that we would call pneumomediastinum, and honestly, we don't really see much at all. So, but this patient had a history of ingesting glass, had some psychiatric issues, and you can see there's the pneumomediastinum up in the, well, I guess tracking up into the neck, mostly gas there, and then the cervical esophagus looks a little thickened. But what's kind of crazy is as we go down right here in the esophagus, we see.
Oh, geez.
Yes, this thing. We put on a coronal for you. Yeah, this is a piece of glass or something. It's opaque. Now the CT followed the radiograph. So you can see it's got a straight edge there, so it looks like a glass shard. And it's easy to see on CT, but going back to the radiograph, let's bring them up side by side. Let me get my GoToMeeting out of the way here. We can, knowing where it is, you can sort of hallucinate, I think, the top margin, but you're not going to see this prospectively. I just couldn't convince myself it was there. Glass is really hard to see, especially overlapping the spine. You can pick it up on extremities where you have fat, but and it's usually loosened relative to it. But this is a big piece of glass, but it causes cervical esophageal perf. And then on the esophagram, we can see you can see right there is a little leak right there.
Oh, that poor person. Oh,
Yeah.
dear. What a terrible
I've
situation.
had a history of a lot of glass ingestion, so that's a problem. Okay. Hold on a second. Let's see here. Oh, this was just a really pretty case. This is one of the best examples, and I actually have biopsy confirmation of this case. This is one of these patient. It was a history of carcinoid, and you can see these lungs are very heterogeneous, and there's all these well-defined nodules all throughout the lungs, and then this mosaic attenuation. I don't have any expiratory images, but this was a middle-aged female, and they ended up wedging out at least 2 of these. And on the path report, several of these nodules were typical carcinoids, but they also confirmed what we all suspect is there's also diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, so DIPNIC. Usually we don't biopsy them because it doesn't really change much, but this was done elsewhere and then referred to us. And I don't know what the treatment really is other than just managing the carcinoids and any respiratory stuff. So
Jeff,
yeah,
the nodules in DIPNEC should be central lobular, correct, and not random. So you don't expect to see them immediately subpleural. Am I right about that?
I don't think that's necessarily the case because most of the hyperplasia we don't even see. We see the effects of it through the air trapping. These carcinoids are too big, and they can start anywhere. There's neuroendocrine cells, and then just grow. I mean, some of them are central lobular, but I don't use the distribution of nodules in particular for that. But you could argue this one's probably central lobular trying to be.
Yeah, I too think that they're random.
So, a couple comments here. Number one, there has been some recent literature that somatostatin analogs can help with symptoms.
Okay.
That's been published within the last couple of years. Number two, Brent Little authored a paper that was in AJR maybe a year ago now, that from our time at Emory, and most of the nodules are in a peribronchovascular distribution.
Okay, which would make sense because that's where a lot of the neuroendocrine cells are. Yes, like these here.
Yeah, I think we had 30 patients at Emory that he reviewed for that.
Yeah, I remember you guys had a really high number of cases of DIPNIC down.
For whatever reason.
Yeah, I don't see it as much. Anyway, this one has some of the better air trapping I think I've ever seen with it.
Very much so, yeah.
Yeah, and there was no the outside path report was confirmatory. I was hoping we'd have it because I knew subsequently that they had this was an outside scan, they'd biopsied it, and you'd figure unless you needled it, if you did a wedge, you would have the surrounding lung and be able to confirm the diagnosis. Okay, and I just have one more nice case. This is something I was talking to one of our ILD pulmonologists, and they're seeing more of now in their clinic, and I'm sure you guys are seeing it too. This was a patient with COVID and has a nice, just really quite advanced lung injury, and probably not fresh acute because we already see some crazy paving, but looks like a very extensive organizing pneumonia with consolidation. But what we're starting to see now, and we've talked about it, and I know we've seen cases of it, is what happens to some of these patients. And this one you can see really started looking, this one's one of the better ones I've come across, so I saved this one. Really looks like NSIP. There's probably still some areas of OP left in there, but just like with other acute lung injuries, we're seeing some patients presenting with residual symptoms, and in this case, full-blown fibrosis. But it looks different than the ones I've seen that were on the one. We've had a few patients that had really severe lung injury that were on ECMO for many weeks, and we've transplanted at least one, and they just had completely trashed lungs, and this one looks just more like severe OP moving on to NSIP. And I think some of this will at least go away, but I think the stuff at the base this is probably here to stay. But why we're seeing them more in clinic now, I don't know. I think it's probably a product of the fall surge we had here in the United States, and now we're about 8 to 12 weeks out, and then the ones that aren't getting better are starting to show up.
Yeah.
Okay. Well,
Thanks, everyone.
Yeah, top of the hour. Thanks, and talk to you next week.
Thanks, everyone. Nice cases.
Yeah.
Interesting. Very.